So welcome everybody to the Council of Governors meeting today on the 2nd of March. We just missed St David's Day by a whisker, but happy St David's Day for yesterday. Apologies, Anu, for this meeting.
Yes, I have Deborah Hughes, Shashi Irakula, James Thomas, Chris Kane, Arun Thiagarajan. Emma and Helen may possibly not be able to make it, but they may be able to.
Okay, well, we'll take that as, and I think we had apologies from Chris Ketley as well.
Oh, did we? I thought it was Chris Kane, sorry.
I think it was Chris Ketley, I think.
Thank you.
Okay, and just like to extend a welcome to John Machin, who has joined us as of the 1st of March as non-executive director in waiting for when Merrick disappears in July. So welcome, John, your first Council of Governors. Anybody else new here? I don't think we've got anybody else new, have we, Anu?
I forgot to say that we will have Julian Roos and Susan Holton attending to cover off James's parts on the agenda. Unfortunately, James is off sick.
So Julian and who was it?
Susan Holton.
Oh, Susan, yeah. Yeah, sadly, James has succumbed to the virus. So one of those things, I think, at the moment. Okay, any declarations of interest on anything that's on the agenda, please? No. Okay, good. Thank you. So we'll start with going through the minutes of the meeting dated 8th of December. And I'll just ask for any comments as we go through. There's 13 pages of them, so we must have been quite voluble at this meeting. So anything on page 1? 2? 3? 4? And 5? 6? 7? 8? 9? 10? Oh, it was 10 actually. Yeah, through the actions. So we'll take those meeting notes as agreed then. Thank you. The minutes. And then we have the actions arising. So the first one was Louise. Louise, you're going to provide a further update on this action at this meeting.
Sorry, Andy, I'm just trying to open my documents. Can you just remind me what the action is?
Yeah, this was provide further detail on the work being undertaken with the South Regional NHS Improvement Team retention workforce requirements. And it's been postponed twice, and you were going to provide the latest update.
Yeah, I mean, I did say to Anu, I'm not sure that this was technically an action for me to come back to the Council of Governors on, because it was a comment that I'd made around during a meeting. I had an interest in the potential impact of people retiring earlier, and I'd offered to do some work with NHSI around some data analysis, which actually hasn't come off, Andy, if I'm honest. So we've been back to them a couple of times, and it's not something that we're pursuing. But what we have done as an alternative is we put ourselves forward as one of the exemplar sites for implementing the people promise, which is all around retention. So basically making the organisation the best place to work, picking up a lot of the issues around how you might improve on team relationships, on culture, etc., etc. So all the things that we're really interested in. And nationally, they chose 40 sites to be exemplar sites, of which we are one of them. And what comes with that is a resource, which is great. So we're going to get a people promise manager that will be able to go and do quite a lot of the, not quite a lot, but some of the work that we had planned around cultural refresh and other areas of retention. The other thing that people might be interested in is that NHS Employers and NHS Improvement have published our toolkit today on retention. So they brought together what they know in terms of best practice around this, and that's been published on the NHS Improvement website, so available for people to go and have a look at. So retention is very much a focus for us this year, and as I said, we are part of the national programme as an exemplar site. So I'm sure that the People Committee will hear more about that as we progress. So
Okay.
hopefully that's enough of an update to close that action off the council agenda.
I think we can close that action, and I think the when you've got something to report on the exemplar, I'm sure you bring it back anyway. We don't need a formal action on that, but because that will be picked up through the committee.
Yeah, thank you.
Okay, so the next one is complete. The next two are complete. So the next one was the membership and community engagement group, liaise with Director of Strategy and Sustainability and Edwin, relinking in with the strategy and becoming a community hub. Now, I don't know if that is Tom on. Tom, has that happened?
That hasn't happened yet. I mean, I think it sounds like Lillian, Edwin and I need to hook up outside of the meeting, so we haven't done that, so we will.
Okay, so can we put an action that you've done it by the next council, please?
Yes, assuming that my colleagues are happy with that. But yeah.
Yeah, okay, thanks.
Sure.
The next one is complete. The next three are complete. Collaborate, draft trust strategy refresh, share feedback from Woking Borough Council. That was on Deborah. I know she's on the meeting, not on the meeting today. Did she feed back the Woking stuff to you, Tom?
Well, we had the session with the Woking Borough councillors on the 5th of January. It was a very good session, actually. We had a really good conversation with them. We went through the strategy refresh feedback and had a debate about that, and we talked about the issues surrounding transport, etc. So I'm not sure there's anything specific to feedback on, other than that we had a good discussion.
I think that's right, actually, because the date of this precedes the meeting with Woking Borough Council, doesn't it? So, and we had a good, and Deborah was part of that discussion as well. Okay, so we'll close that off. The next one was once governors, right, so this was just a general action, I think, and it wasn't it, that if governors, once they'd seen the draft strategy refresh, wanted to forward any questions, they could do via you. Did you get any, Anu, through?
No, I didn't receive any further comments on that.
Okay. So we can close that one off, and the next one's complete. Okay, thank you. So we'll move then to governor activities, and I'll hand over to you, Shirley.
Okay, it's really been quite a busy few months for the governors, and as well as doing the regular meetings, they've been involved in quite a number of extra ones this time, and these have been things like the Chief Executive recruitment, the Associate NED recruitment, appointment of the external auditors, the well-led review, and last but not least, one-to-one meetings with yourself, Andy. And on behalf of all of the governors, we'd like to thank you for taking the time to have a one-to-one with each and every one of us.
You're welcome. I enjoyed it, and I've got some feedback later for that, on general feedback on that.
Okay, that's all for me.
Okay. Any questions, Shirley? The numbers of meetings are all there. As you say, lots and lots of meetings this time. I'd just like to say thank you to the governors, because we are aware that, you know, this is all unpaid work, and you know, in particular on the recruitment side, it's been very, very helpful to have governor input on both Chief Exec and the Associate NED recruitment. So thank you for that. Okay, so have we got Chris Howarth yet.
Yeah, I'm here.
Ah, Chris, thank you. Can I hand over to you then on the patient experience group report, please?
Yeah, and I'll try to be a bit briefer than I was last time. So you have the report before you, and I'll take that as read. But it was gratifying that we had a number of the newest cohort of governors wishing to join the group, and that means that we're therefore at full strength and covering the full breadth of the trust's catchment area. So I think that's a good thing. I'd like to extend special thanks, fulsome thanks indeed, of the group to Eleanor Morgan, who took us through a detailed review of Viewpoint, the trust patient feedback system. Whilst we were disappointed to hear that the current response rates were only around 5%, we were impressed with the detailed plan to reach 20% by September this year, and look forward to interim updates on progress. And then finally, I'd like to thank Jackie Rees, who stood in for her engagement with the quality report, as she stood in for Andrea, who would normally do that. So I leave that then, Andy, back to you for questions.
Thank you. Any questions for Chris? The thing I picked up, Chris, which also I discussed with Derek, was his input on Dickens ward that helped increase the response rate. And I think, you know, having volunteers for that would be actually most welcome, I think. So it seems to be a good way of doing things.
That was that was a sort of key finding, and I think if you're ready to have more volunteers in the hospital to do specific things like that, then I agree with you. It'd be very good if we could reach out to people and get them to do that.
Yeah, and I think through Anu to Andrea, really, on anybody who is interested, and certainly I've actually spoken to Andrea about it, and she's aware of it. So got some other questions. Jane first.
Thank you, thank you, Chris. I just wanted to assure the governors that we always review patient experience at every quality committee, and it is a key focus that we are, I think, the same as you are. We do feel that we really do need to focus on getting our numbers up to get some meaningful numbers. So this is something that we question at every meeting, and we start the quality report with patient experience feedback and where we are with it. I think the other thing to recognise, of course, is patient feedback isn't just about Viewpoint, it is much wider. And I think it's important that, you know, we think about the other things that we do for patient experience around arts and around engagement. But I think it's a really good point that we really do need to get those numbers up. So thank you, Chris.
And Joe, if it wasn't made clear in what I said, it was set out for us really clearly what steps and what actions were being taken in order to get that. So it wasn't just we want to hit 20% in September. There was a route plan, so route map set out for us in how you were going to get there.
Excellent, that's good, and we will certainly keep an eye on that at the quality committee as well. Thank you.
It's so important to get statistically significant feedback, because 2% is not statistical. In fact, you'll probably only get the very, very good and the very, very bad, what I call the TripAdvisor effect. Otherwise, John, Nature.
It was 5% though, John, not sorry, Andy, not 2%.
Okay, 5% still doesn't meet it though, does it? John, Nature.
Hi, Chris. Good to meet you again. Yeah, I can understand the difficulty in terms of getting feedback, but it was really to explore the issue that Andy had just raised there, that TripAdvisor effect, and whether it was the 5% tended to be people who were dissatisfied with their experience, or were we finding anything else?
I don't think it was that 5% when they say dissatisfied. It's just the fact that the 5% is just too low to make any meaningful.
Yeah. Okay.
Great, thank you. Andrea.
Yeah, it was just to follow up on that point. It's so the feedbacks is mixed. We have obviously patients that and relatives that feedback to say if there's particular issues or they feel there's any areas for improvement. They say, but we do get a lot of compliments, real lot of compliments via the platform. So and we do show that as well at the Quality of Care Committee, as James just mentioned. I just wanted to add really that there is a, as you've already mentioned, Chris, there's a quality improvement wraparound this actually to get where we need to get to. And it's obviously not going to be an overnight thing, but it's just to give that assurance that we have there is a real focus on this from a quality improvement perspective, and there's a team focused on it.
Yes, there's all sorts of ways of patient feedback, isn't there? Having had my ear thoroughly bent just over lunch, which I'll talk to you about later, Andrea.
Great.
Yeah, I've had a better hour. Right,
Andy,
yes.
may I just check one thing for us? What Jane just said triggered something. So we had asked which NED had responsibility for patient experience, and I think you had essentially said, look, we can't have a NED for every single area. This is something that we look at generally. Just what Jane said, I was wondering whether in fact Jane was essentially saying that she was chairing a group that was looking at that. Could we just be a bit specific so we can record that at our next meeting?
Yeah, it is the quality committee that looks at that. Yeah, and you're quite right. Yes, we're in fact latest NHS England guidance is not to have NEDs apart from very, very specific cases like the maternity NED, which actually Jane is, but to have board committees responsible. So the quality committee is responsible for the assurance around patient feedback.
Thank you very much.
Okay, so thank you for that, Chris. Thank you for those questions. Lily, the Membership and Community Engagement Group.
Well, I'll be brief as well. You have got the minutes. We have got now full complement, well, not exactly as full complement, 2 new members. And thank you, Andy and Miranda, for joining the group. But we would still like to have somebody from Elmbridge, because it would be very useful to have somebody from each of the constituencies. And we had a very good report from the Deputy Head of Communications, and have agreed that we will look in the ways in which we can get closer to the community. I think one thing to point out, which is not in the minutes, is the total number of members, and Anu can tell me if I'm wrong, but it is over 7,000 people. So when you see the figures saying that we have lost 49 members, you have got to put that in comparison with the total number of members that we have. And we do need, given that we have got such large number of members, the clarity about what is the benefit of membership is not really there yet. And we need to look into it.
Thank you, Lily. Any questions for Lily, or indeed volunteers from Elmbridge for that committee? Tom.
Sorry, struggling to unmute. I think it's just a point of clarity on that last point by Lily, which is 7,000 is, I think, if I'm correct, Lily, the number of non-staff members. So there's an additional 4,500 on top of that, just so that we're absolutely clear on that point in the minutes. It's a significant number of people.
That's completely right. Yes, thank you, Tom, for clarifying.
Yeah, it does make a big difference, doesn't it? So it's about 2/3, 1/3, isn't it? Okay. Francis.
Yeah, I'm an Elmbridge governor. I'll give it some consideration, Lily.
Thank you, Francis. Very helpful. Edwin?
Oh, hi. So I think in our one-to-one, Andy, we discussed briefly maybe when Lily mentioned benefit of being a member. So when I was a membership manager, we used to go to schools and colleges, and a lot of younger people can see the benefit of putting something like that on their CVs, showing that they're active citizens. And it's, you know, when you're starting out and don't have much on your CV, things like this can help. So I think we should consider going to schools and colleges.
And actually, Edwin, Tom and I are going to go and visit the Bourne Academy shortly. We're trying to set that up, and I'm sure they'd be really delighted to kind of float that amongst their members. So I think we can absolutely do that, and,
Yeah.
and not just with them, but they are very willing to do things with the NHS. So, Francis, is your hand still up? Is that an old one?
It was, but I've just thought of another one.
Okay.
If we were looking to encourage, for example, deaf people, there would be an issue around funding for interpreters. So that might be something that needed to be looked at quite carefully.
Yes. I think we are. I'll leave it to the committee to have a think about that as well, about where we want to go. I think Tom and I will try and open the doors. I'm doing a royal we here, but I really mean Tom. But we will open the doors with the various connections we've got with the local schools now. And then if we have the initial conversations, then they can be followed up. Okay, good. Any others? No, thank you. So we're going to move on now to the assurance report, and I'll ask David to lead off on that. Those of you who've been to the board meetings will recognise it, of course, as being most of, but not quite all of, the board report. But I'm sure David would also like to bring you up to date with anything that has been going on over the past month since the last board. David.
Yeah, thank you, Andy. Can everyone hear me? All right. Yeah, so I mean, when I said to Andy I was going to present this, I looked at it and it seems such a long time ago, I have to say, but it's not that long ago. So so the report, as you're aware, it was presented at the at open board. So most of you have seen it already. And really, it's in two parts, but really three parts that we're going to do today. Simon will give you an update on the finance, and the first part is a summation of the risks, and it's really taking on board what we discussed at the sub-board committees, our board assurance framework, our key performance indicators, and the corporate risk register. So it gives a summary of those. And I suppose in terms of, well, what's been happening over the last month, and actually comparing it to the last report that we reviewed in December at the Council of Governors. So I think the first thing to say is the staff in the hospital have been working unbelievably hard, and what I'd like to do is thank you all for supporting them with this, because the pandemic, despite what Boris says, the pandemic is continuing, although in different forms as we progress. And if you look back on the report that was presented in December, you can see that the number of COVID we had in the hospital was about 30, and now we're about 80. So that gives you an idea that although the sickness rates and the ITU admissions have stayed low, which is absolutely fantastic for all of us, we are still seeing significant numbers who are coming into hospital, and actually they're staying in hospital. And what we've noticed as well is that the transmission within the hospital is higher. Part of that is the hospital is much busier than it has previously been, and that increases the risk of transmission. And also, when people have COVID, even when they are well enough to go home, it does slow their discharge home as well. So I suppose what that does point to, and further on in the report, you can see in the quality agenda, we talk about the main effort of the hospital. And that is really what we need to do, is we need to only have people within the hospital who need to be here for us to help them. And actually, although patients have other needs, most of the time, what we need to do is work out how we can deliver those in their home or in another environment which keeps them away from where the virus is living. So that is putting strain on the staff in terms of the busyness in A&E and the fact of the number of patients in the hospital. To give you an idea as well, is that we in our hospital we've got about 550 beds, of which 100 were closed because of nosocomial transmission. That doesn't mean that there were 100 empty beds we couldn't use, but there were about 25 empty beds in that. So that gives you the scale of the issue that we're working on. Having said that, the team have been amazing, and they've been caring and looking after people, and that's been fantastic. And also, we've been switching on the elective surgery at Ashford. So we've opened up two of the elective wards there, and we've started increasing the numbers of patients who have an elective surgery. So that's really, really great news. I suppose in terms of things that we talked about in the last report, the other thing was the CQC report. So the CQC came in at a very busy time, and they were really impressed with lots of things that they saw that our teams would be delivering during this time. But one of the things that I mentioned in the report last time was that was some unhappiness and disengagement from some of our clinicians in theatres and anaesthetics. And what we're doing is we're looking really deeply at that. We need to understand that. Now, this team has been under enormous changes during the pandemic and had to flex and move into different areas and work in very different ways. But we need to get under that and understand what is driving that. And Andrea, myself, and Louise are putting together a program or continuing a program with the CQC, which we are due to report at close board, to really try and understand in greater detail. And we have done a great deal of work on that, but there is a lot more to do. And what I'm just asking you, governors, is if you keep engaged with that piece of work as we go through, and clearly feedback to me, if particularly staff governors, if you feel there is something that we're not covering. I think that's the main things in part one that I wanted to bring up. I'm very happy I will just pause there briefly, and I'll answer any questions around part one and the risks that we're seeing. But in summary, therefore, the risk is mainly around our workforce, which is tired and weary and stretched over a big area.
Thank you, Dave. Thank you, David. Questions for David on part one? Lily.
Just a very quick one. We have noticed that reporting on Omicron is changing. Now, how does that affect, first of all, in what way is that changing generally and to governors as well? And secondly, how does that affect your operations?
Yeah, so there's two things that are going in parallel here, and Andrea might want to come in here. I mean, clearly it's really, really good news that Omicron is not as lethal as it was previously. And partly that is due to the success of things like the vaccination program and the booster program that we're all involved in. But there is still a risk, and that was what I was drawing out from this. There is still a risk in terms of hospital and in terms of delaying people's transfer out of hospital when they're well. And there is also, we've had quite a long discussion with our anaesthetists that if you do have Omicron or if you're recovering from Omicron, there is still an increased risk if you're having major surgery. So it's a balance of doing those things. So on the one hand, we've got the message to the public that Omicron or the pandemic is a thing of the past and we can relax a lot of the restrictions. We're maintaining those within the organisation at this time. So clearly, infection prevention control is still really, really important. Wearing masks around the hospital and within 2 meters of people is really important, and practicing infection prevention control, gloves, aprons in the appropriate environments continues to be important. And we're also continuing to screen people before procedures, although we're probably changing the way we do that. So we're looking to change it from isolation and screening to possibly screening alone. So it's made more change in the public than it is on the operational delivery at the moment. And I suppose the nosocomial transmission I talked about is absolutely why we need to be on our guard for COVID at the moment still. Does that answer it, Lily, or did you want to add anything else, Andrea, at all?
No, I only support. You know, I think you said it already, David. I think that, you know, although the nationally the direction is to relax the controls from a healthcare perspective, clearly we're still under pressure with the admissions that we're seeing with COVID. People are becoming ill with COVID, and Omicron is definitely more transmissible. There's no two ways about it. So and I think we're seeing the effects of that within the organisation. So still sort of a bit for us. It's we can't really relax on this. Not that we would, but you know, I think this month in March is going to be a key month just to see if our numbers do, hopefully, fingers crossed, our COVID numbers do start to reduce as inpatients. But if anything, they've been doing at a level, and they've started to go up slightly of late.
Yeah.
So.
Well, in December they were at 30, and we're now at 80. So shows you where we've been.
Andrea, probably worth saying that obviously the self-isolation is still applying to us as health workers.
Yeah.
Yes, that's right. There's been really no change for healthcare workers. To be fair, we're still following the guidance of we've got to self-isolate, become positive, and if you are a contact of somebody who's positive, you know, still have a PCR test and do the lateral flow test, and day 5, day 6, you know, check the negative, and you can come back to work. But it's so yeah, controls really tightly still in place, and visiting as a consequence. I know it's quite emotive, is still restricted. For us, and it doesn't feel, I mean, we're reviewing it constantly, but at the moment it doesn't feel right to relax, although I know relatives are really keen that we do, clearly in light of the national guidance, but it's not right to do that at the moment. Reducing the footfall is quite a key measure in preventing and reducing transmission.
Okay, thank you, Andrea. John?
David, with regard to the CQC comments, it was just that thing about the theatres comment. And whether there was more details. I mean, were those issues known about before?
Yes. So we've known about those for some time. There's been some whistleblowing that's been going on for some time in a repeated way, and they've been investigated, and we've engaged with the team for a long period of time. So we have done a lot of work, and I see that I think Louise put her hand up, and Louise may want to come in and just give a snapshot of all the things that we've done and the program going forward, which we need to review. Louise, do you want to come in and just mention that?
I mean, I won't go into detail because I think, as you say, that was to do with the board, and then to bring assurance back to the Council of Governors. But I think as with everything, this is complex. I think since the CQC have been in, and since we've been talking to the Council of Governors around some of the cultural issues that have come out of things like freedom to speak up reports, and also the whistleblowing, we've actually had the staff survey, so that's given us another level of feedback that's been really useful for us to be able to really identify where we think the unhappiness and the concerns are. And so a fairly detailed report was presented back to execs last week with some of that analysis. And I guess what it's shown us is that that one intervention isn't going to fix all of this. It needs to be a combination of lots of things. And we've already started that. I think if you remember, about 6 months ago, I talked to you about the work that the division had done to improve the way in which they communicate within theatres and anaesthetics. They've done a really good newsletter that continues to be published. And the focus around that is recognising the team members, what they're doing, what they're achieving. They've done a huge amount of work around wellbeing, and they've got a number of wellbeing champions within the division that are very active within my wellbeing network. So that's great to see that. They've recently developed sort of co-produced, led by 2 of the consultants, a charter for theatres. So what are the behaviours that we are all going to sign up to when we work within the theatre environment? And so that theatre charter at the moment is being, as I said, co-created by the team and will be implemented. We are doing a particular piece of work with the consultant anaesthetists because they are a group that we've identified that there are some there's a necessity to bring the teams together and do some team development, a team review, and again as a team of consultants, and they are the biggest team of consultants that we've got. There's about 30 of them, so doing some work with them as a team, led by the PPA, so that's an external organisation that spends quite a lot of time working with the medical workforce, and they're going to help us with that. And we've had 2 of the consultants, a consultant anaesthetist, offer to be the sort of champion of that work. So again, that's something that we're trying to not have as being a leadership-led intervention, but something that they're doing themselves as a team. And then the final piece is, because it isn't just about the doctors, it is about the whole team. We are piloting a piece of work, and you can have look up the company if you want to, but there's a company called A Kind Life. They've done quite a lot of OD interventions in the NHS around kindness, compassion, respect, civility, and they're doing a programme of work with us around supporting people to be able to resolve issues themselves and resolve issues within the team, as opposed to things, always being escalated. So that piece around how do you create an environment where people are able to do constructive challenge, which is given in the right way and accepted in the right way. And so we'll see how we get on with that. So as you can see, I mean, it's something which is, we're constantly thinking about what's the next layer of the programme of work, but we also have to recognise that we don't want to overwhelm those teams. The work that James and David and others will be leading around restoration of services and the reconfiguration of the Ashford Elective Centre will mean, again, that their world is going to change quite a lot. So actually what we need to learn is how do we get them involved in that and feel empowered in that, so that this time next year when they're doing a survey, they don't feel disenfranchised by the next change that we need to do with them, but it's something that they do with us. So as I said, it's not a straightforward piece, but it is something that we are trying to use a range of OD interventions, and at some point, we will be able to say, are we being successful? I guess the other thing that is really difficult is that the whistleblowing is all anonymous. So the CQC can't investigate it really, apart from asking us to provide an explanation as to why something might have happened, so they can see if there is any evidence, and we can't investigate it if it's anonymous. So that's quite difficult, and in a way, having a conversation with the CQC about how do they measure our success as well has been a really useful conversation. So yeah, we're not there, but we absolutely understand the need to improve things for people. We want it to feel like a really good place to work. Some of it feels counter intuitive in terms of other things we hear when we interview for consultant anaesthetists, for example. We have like the pick of the most brilliant trainees. So there is something we're doing right within these teams for people who want to continue to come and work for us. But we need to make sure that we're constantly learning and constantly improving in relation to this sort of team working and team dynamic.
And it's worth saying, I think, that a lot of the whistleblowing that led to the CQC review was all around safety in surgery at Ashford, and they came and said that Ashford surgery was safe. In fact, that was the bit they upgraded. So it's that's not to say that any of the work isn't required, because it's all required, but it isn't just another interesting fact that they found. Okay, so Chris Howarth.
Yeah, if I could just bundle some questions there, if I may. I guess for David, really, you mentioned about the increase in number of people in the hospital with COVID. Can I just check if the reason for them being in is primarily COVID, and that's why they're in the hospital, or if it's that they're in the hospital for some other reason and they also have COVID because of the community transmission? And then the second question was about the staff vaccination mandate, that the government's removed that. Are you seeing as a hospital that as a positive, or as a negative, and if it is a negative, how are you dealing with that? And related to that, I guess the staff absence rates. How much impact is staff absence due to COVID having on the trust operation, and how are you managing that and assuring yourselves around it? And I guess finally, Andy, you mentioned in our report on PEG the volunteers and the benefit of volunteers to the response rates from patients. But to what degree are you welcoming volunteers back into the hospital, given the issues with COVID, and to what extent do you need us to wait until we're in a better place? That's all my questions. So thanks.
I hope somebody was keeping count of those questions.
Yeah.
But
Can I start, Andy?
Well, there's one thing though. Vaccination. The vaccination instruction is on the agenda, so we'll deal with that later in the meeting. So we can take that one later. But the others, yeah.
Shall I start then?
Kick off.
It's a really good question about, well, how many come to hospital because of COVID, and how many are in hospital with, and probably more than 50% of people are in hospital with rather than because of. So the problem is what we're seeing in the community, that the prevalence rates are just so high. We've never seen them even now as high as they are. So your chances of being asymptomatic sitting in the community with COVID are high, and therefore, if you have something wrong with you, you're likely to, quite a few of these people have got COVID. Plus, as well, is that we've seen nosocomial transmission as well. So when people are in hospital with lots of other people with COVID, the chance of you getting COVID increase, particularly with this variant, which is so contagious. So there are two reasons for that. And then the third reason is that when you have COVID, you're onward traveling. So discharge to a residential home, a community home, sometimes looking after carers in your own home is delayed because of COVID and the concerns about the teams that are looking after them. So it is difficult, that. In terms of absences from COVID, we have had absences. I think our absence rate, I mean, Louise will correct me if I'm wrong, but I think we got up to about 4.5% total absence. But actually, lots of other organisations had lots higher absence.
Yeah.
And the problem with it is that there were lots of people who needed to take leave, not because they had COVID, but because their school children had COVID or relatives had COVID, again because of the high transmission rate. So it's a very complex picture. But I think we had less sickness than a lot of areas that I saw. And if you looked at some organisations, I mean, their sickness rates were 15% and higher than that. I mean, the ambulances, I think, were extraordinarily high. So it's very, very variable. Is there anything else we should say about that, Louise, at all?
No, I've just put in the chat Friday's data, so that was the most recent. So total 4.9% sickness absence, of which 1.3% was COVID. I think at our peak, we got up to probably about 3% COVID absence and about 3% additional absence, and that was at the beginning of January. But it's been falling ever since, and we are in a more we're definitely in a different place to a number of organisations. SASH, as an example, tend to have much higher, 3 times as high as we do. We have done quite a lot of work to make sure that our sickness data is validated and recorded, because that was always a concern. And so we do feel that this is as accurate as it can be. I guess the other thing to say is a lot of people have had COVID and are not in the office with COVID, but are still working. And so the kind of, how it feels in terms of absence, and then how that translates in terms of people being able to still continue to do their job, is also a little bit confused. So normally when people are sick, they're sick, but, with this virus, actually, quite a lot of people are asymptomatic and therefore, able to carry on working. So there's a bit of a nuance there as well. But I wouldn't say that sickness is something that has significantly impacted on our ability to continue to be able to deliver care.
I think the volunteers question, Andrea, do you want to take that about volunteers being welcome back? Because I see them in the hospital.
Yeah, I'll take that. I mean, I think
take that.
Yeah. So I think like with all things is that it's not the right time to release to where we were before. From what we're seeing in terms of the rates of nosocomial transmission in the organisation, we do have to wait. So at the moment, although there are some people returning, they're generally smallish numbers actually. I think that's right, Louise, isn't it? And I wouldn't really want to wholesale reduce that at the moment.
Yeah, in terms of volunteers,
Yeah, I'm seeing them they're on the desks, and helping out with, front of house stuff, aren't they? I don't think they're on the wards.
No, so it's limited.
Okay, thank you very much.
Tracy.
Thank you. My question kind of follows on from Chris's, and apologies. I have been away for the last week and a half, first day back today, so it could have been addressed while I've been away. In order to try our efforts to reduce in-hospital transmission, is there assurance for us for the free lateral flow testing? So now the government's talking about withdrawing free lateral flows.
Yeah, so you are right that access to the public getting lateral flows, I think ceases it's 1st of April, isn't it? I think that's when they've published. But we do see this as a very important part of our protection. So I've been away for a few days, but that's what we need to work out. So we will need to work out what's Louise, you're shaking your head there. You're on mute.
My mouse has decided to stop working. And no, I'm agreeing with you. I mean, I can't envisage a situation where we're going to ask our staff to complete a testing regime and pay for that themselves. If we want you to continue to do that, then we'll need to find a way in which we supply that equipment. Is essentially my view. We are still awaiting confirmation of that, but are expecting that would be the case.
Thank you.
Colin?
Yes, just reflecting on what Louise said, I'm sure she said that if an anonymous complaint is made, it cannot be investigated. Is that correct? It would seem to me you may be missing out something.
No, that's not. I think it is hard. It is harder to investigate in certain ways. So the way we did this, some issues were sometimes repeatedly raised. What you can't do is you can't feed back to the person who's raised that. So we investigate them, but you can't feed back to who raised it. So myself and Andrea spent a lot of time doing team talks with the team and presenting all the concerns that have been raised and letting them know that they'd either been fully investigated and there wasn't a concern, or the concern had been addressed, or whatever it is, was the only way we could feed back. We had to feed back in the whole team, as it were, as a team event. So it does make it more difficult to investigate these things, and sometimes it's a bit vaguer. And the interesting thing that we've seen, I mean, there's lots of interesting things, but the themes are repeated, and sometimes the concerns are repeated, even though we've done some of these things. So we need to understand why that is. In fact, Andrew Lansley, when he formed in 2012 the current system we're living under, what he did say was anonymous concerns should be taken more seriously than non-anonymous concerns. And I think that was because people who raise things anonymously may be fearful of repercussions, and that was the reason that he said that. So we do take them very seriously.
Yeah, thank you. So I think we need to move on. David, do you want to?
Yeah, I'll briefly go through my second bit, and then we'll turn over to Simon. So it's kind of, the next section has got some nice highlights to look through, and I think we all enjoyed opening the staff wellbeing hub. It seems a really long time ago now, and it's well used by the staff, and it's a really great environment for people to enjoy. The other one that I want to point out, and it fits with the discussion, that we did have an incident at Ashford when someone needed some more blood urgently, and actually this big shiny bike has been bought, which is linking up the two things, which Andy Hyatt loves driving around, and I think the person who's designated to drive it enjoys that. But that was an absolutely great initiative, and Megan and James did a great job bringing that to us. I'd also like you to draw your attention to the Veterans Award Trust Accreditation. I think that's a really great thing, and I think the continued support of the armed services and the veterans is really important for the trust. I think we seem to be trying to learn the skills of our military colleagues more and more in the organisation, and actually they've got a great deal to teach us, and I think that's a great step forward. And there are quite a number of initiatives that are coming on the back of that, so it's a really great thing. So please support that. And I suppose the other two bits was we had two dignitaries visitors really. One was Ian Smith, who's the chair of the integrated care system, who came around and looked through our services and spent a long time with us, and was very impressed with when he met staff. And the other person was Anne Eden, and Anne Eden came, and we had an absolutely fantastic meeting at Ashford with Royal Surrey colleagues, and we talked about setting up Ashford as developing Ashford further as a regional hub for diagnostics. And this is really on the back of 2 years' work through the pandemic, of us understanding that the separation between elective and emergency care is so important, and the hard work by all the teams, and we discussed that in the earlier piece that we talked about, has given us this great opportunity to develop this as a regional centre. And in fact, if you look at the CQC feedback, the Ashford theatres were really happy and content. The infrastructure is good. They know that there's a great future going forward. And actually, it was great to work collaboratively with our colleagues from other trusts as a system, and we've carried on doing that, working together, and to develop what and how we develop Ashford. I think the other bit.
Oh, we've lost David. I'm coming back in.
He's coming back in.
We'll just do a significant pause for a minute.
As he, can I just fill the gap just by a clarification?
Tom.
He did.
Yeah.
I'm back.
All right. You mentioned it as a diagnostic hub, but it's actually for a diagnostic and elective hub.
Yeah.
So it's both elements. So just to make sure that everybody's clear about that.
So predominantly as an elective surgical hub, and I think it is a great opportunity, and it goes back to Louise's point earlier about engagement. So one of the things we did do is we held discussions, because this is going to have clinicians from other hospitals working at Ashford, and at the same time, the Royal Surrey was suggesting that our clinicians go and do some pieces of work at Royal Surrey. There's going to be much more movement there, and what we did, even before we put the bid in, we held meetings with our clinicians to tell them we've got this opportunity. We think we're going to go for it. What do you think? And that was really warmly received. And the plan is to keep them abreast of the developments as they go forward. So the next stage is that we have heard from the regional office that at the moment Ashford is designated to be one of the 3 regional hubs in the southeast, and we've got to develop the business case to the next stage. So it's a huge amount of work going ahead, but a really exciting piece for the whole trust, for the ICS, and for Ashford in particular.
Thanks, David.
I'm happy to answer questions, but the last bit is Simon to give the update on finance. I just wonder whether we will go straight on with Simon and then answer questions both of us.
Yes, I think let's hear from Simon.
Sure. Thanks, Andy and David. So I think it's page 17 of David's report that the finance section starts on, just to draw your attention to that. It's a tale of two halves, I guess, at the moment. In terms of the current year, then we expect now to be able to land our finances in line with the financial plan that we set in half two. Obviously, we met half one earlier on in the year. There's a bit more challenge on the capital side of things. So we've been pushing through a wide range of schemes. I mean, clearly you'll understand that the delivery of medical equipment can be quite, well, it's certainly been affected by COVID, but also things like the availability of computer chips and all those sort of things. Everyone's pushing quite hard to make sure suppliers are delivering by the 31st of March. So that's really the challenge for us on the capital side. I think the report itself draws your attention to about 1.9 million that we hadn't got confirmation on. We're now below the million mark, and we improve kind of day by day. So the risk around that, is becoming more manageable, really. The future, though, is where all the challenges lie. We haven't had our normal kind of governor's annual briefing as yet, and that's because there's been a huge amount of discussions across the system. We're required to balance as a system now. So new rules are coming our kind of way. And I think Sal, it's like she's talking to someone else, but there's a new date that's going in the diary. I think it's towards the end of March. At the very latest, it might be the first week in April kind of thing, at which point we'll be able to talk through our financial projections for the coming year and the challenges that raises. It's the withdrawal of things like COVID funding, the resetting of the elective recovery, additional funds to clear waiting lists that are causing most of the challenges, as well as David alluded to in his presentation earlier, just the actual level of spend that COVID is still implying across the hospital, whether that's in people covering sickness or extra beds or whatever, really. So for the moment, insurance I'm giving you is around the current year. What's that? 21-22. We should hit our financial plans and performance by the end of March, but more discussions on next year, 22-23.
Yeah, and I think we'll leave the kind of detail of next year until we're very clear, because things are still changing. But the summary for next year really is our costs remain high for all the reasons David has said. People staying in hospital longer, people that do not have a criteria to reside and can't go out to the community, etc. The costs remain high and the funding is going down. I think fundamentally, isn't it, Simon? That's the
significantly.
challenge.
I think it's the word I'd add, but yeah.
So that's the challenge we've got. So I'm aware we're running a bit behind time, but any questions for David or Simon, particularly on this financial year? Okay. Thank you both. Now, as I say, apologies have been from James, but Julian has joined us. And Julian, do you want to draw our attention to, we can take the performance report as read, of course, but do you want to draw our attention to any particular parts of it before we open for questions?
Yeah, absolutely. Thank you, Andy. I suppose echoing David's update that during January and February, we've had a very high number of inpatients with COVID and a high rate of infection in the community, which has created immense challenges within the hospital. It's manifested itself in an increased number of inpatients with COVID, last-minute cancellations by patients due to attend outpatient appointments who have COVID or are required to isolate because of COVID, and also staffing difficulties due to infection and the requirement to isolate as well. So winter's always a difficult few months, and I think it's fair to say that this winter's been no different, although probably even more challenging due to the protocols required that we have to introduce to minimise the transmission of COVID infection. In response to the Omicron surge, the Trust introduced a surge rota from about mid-December throughout January, transferring staff from planned care to urgent and emergency care, which as a consequence meant that most routine operations were halted between mid-December to end of January a couple of specialties slightly into February as well. However, we continued with urgent electives, trauma electives and cancer electives throughout that period. I suppose furthermore, as David mentioned, a number of elective wards at Ashford were required for urgent and emergency inpatients due to the very high occupancy at St Peter's, and the infection protection control measures, again, that David mentioned, where wards were required to be quarantined, has created a very challenging environment for the trust and the activity. Despite this, due to meticulous planning and transfer of activities, we've recorded fairly strong RTT performance for January. This can be seen on charts on page 10. You can see in the bottom right hand corner, you can see our position based against the national average. We remain about 15% higher, which in terms of RTT is actually quite considerable. And then page 11, as we've been moving through the recovery and restoration, you can see that the comparisons, the number of patients over 90 weeks has dropped down to 0. Number of patients over 78 weeks is maintained at 3. And the number of patients over 52 weeks was about 105. Putting that into perspective, again, each patient is obviously extremely important for us and to get in to treat their symptoms and disease. But to put it into perspective, our neighbours, Royal Surrey, have got approximately 500 patients waiting over 52 weeks. Frimley, a close neighbour, has got 1,500 patients over 52 weeks. And again, another neighbour that's not too far away, University Hospital Sussex, has got 7,000 patients over 52 weeks. And that's replicated across the country. There's huge challenges out there. We started in a pretty strong position because of the RTT work, the referral to treatment work that we've been doing over the last couple of years, and all of the efforts during the pandemic and as we move out of it as well. So we do have challenges. It's not all rosy. On page 12, you can see that we've got demand exceeding capacity in a number of specialties, especially dermatology, gynecology, and neurology. We're aiming to secure additional capacity to address those imbalances. And also, I believe James mentioned in a previous Council of Governors, we've got an overdue follow-up backlog, and we've been implementing a number of initiatives to resolve and support the reduction in these through a number of initiatives. They're detailed in the paper. So basically permanent clinic template changes, a reduction of first outpatient appointments between April and June, business planning to obviously increase capacity, and greater use of patient-initiated follow-up to release capacity. Just very quickly then moving on to A&E performance, we've showed marginal improvement compared to December, although January was a very challenging month because we had very high occupancy, staff shortages and similar challenges being experienced by our community colleagues as well, which restricted our ability to discharge patients where additional community support is required. Again, I suppose on throughout the document, you can also, I put the comparator in there with regard to our position against the England average, which is on page 16. You can see that the trust has remained more resilient and higher than the England average. There's quite a number of other metrics included in the paper with regards A&E and hospital flow slides, which identify clearly, obviously, some of the challenges that we're experiencing. But it's good to know these are improving as we move on from probably what's our most difficult time of the year. I've seen some of the February figures that are coming through in all of the metrics, A&E, RTT, cancer. They're all starting to improve, so that's definitely good news. Just moving on to diagnostics as we move through the paper. We've been running at maximum levels to try and recover and restore services, and we reported a marginal improvement for December. We're expected to also report improvement in February as well, although unfortunately due to best efforts, we haven't improved as much as we'd like, because we did have a considerable amount of staff sickness in the diagnostics teams, hence they were required to isolate, which did reduce quite an amount of our capacity. Again, it does show improvement. We would have liked it to have been more, but obviously we need to remain safe for staff as well as patients. Obviously, there's some interest in endoscopy, so I'm going to pull that metric out. Endoscopy, similar situation. We lost a considerable amount of capacity, generally from our partner. We've got a partner provider in health. They had COVID sickness throughout January, and hence it reduced capacity. Although, again, we have made a marginal improvement in endoscopy, and I have seen February's statistics starting to come through. Again, they're looking far more promising. For cancer, we saw, again, like I mentioned, similar challenges, including patient choice and patient COVID sickness, which impacted on quite a number of cancer performance metrics, impacting 2-week rule, 28-day as well as 62-day performance. We generally do see that around December and January because of how patients interact with the organisation. But despite these difficulties, we've been able to regain grip through back end of January and February. And I can see that some of the metrics for February are looking much, much better improved. So it's been a very challenging time, although the Trust does continue to deliver as best able with good signs of improvement being seen as we move out of winter.
Thank you,
Julian.
Julian.
Any questions?
Thank you, Julian. Just to remind governors, obviously, role of the governors is to hold the non-executives to account. And I just wanted to be clear that this performance report, good old James gets grilled 3 times on this report. So apart from board, he goes through modern healthcare, chaired by Merrick, and goes through quality committee, chaired by Jane. So I can assure governors that this report is taken very, very seriously and gone through in a lot of detail at those committees, and then in less detail at the board, just so you're assured on that. But I'm sure Julian can answer any detailed questions you may have.
We've also got Susan on the line to feedback on the outpatient steering group.
Yes, we're going to do that next. Thanks, Julian. So no questions on that, Julian? I think the summary, very, very tough, doing comparatively well, but that's not a thing to rest on laurels, because comparatively well against the national standards is still, for entirely understandable reasons, we're still a long way off the national standards, but it shows how resilient the team have been actually, and in fending off the worst of this pandemic and its effects.
Sure, and they're huge efforts from everybody involved.
Absolutely, absolutely. Jane.
Just to say, really, to support your comments, Andy, that we do review this quite closely at the Quality Committee, and very much our focus is around harms and just checking that any patient where there are delays in treatment or where we are having particular issues, that there is a process around making sure that patients' notes are reviewed by a senior clinician to ensure that patients are seen in order of clinical priority. And that's something that we receive assurance at each committee, because that's really important where we have got patients who are not seen in the time that we would like them to be seen. And another area where we've had some concerns are around A&E, where patients may be waiting in A&E or for quite some time, or they may be moved more than 2 or 3 times into different areas of the hospital, which obviously has key risks relating to infection control and also is not pleasant for patients. However, we've managed to make improvements in that, which have been really good to see. And I think I really must congratulate all the teams in the key work in a very challenging time, really, in actually maintaining, a good performance when compared with many of our peers. So well done, Julian and James, in your key work in that.
Thank you, Jane. Very, very helpful. Okay, so let's move on, because we've got lots of things on the agenda today. And Susan, you've seen the paper on the outpatient review. I know a lot of governors have been really interested and exercised by the the issues we've had around this. So Susan, I'm going to hand over to you to lead us through. You can take the paper as read though.
Okay, can everyone see the screen? I'm just going to talk through to it and then obviously take any questions afterwards. So my name is Susan Holton and I'm the General Manager and I look after Outpatients. So I've come today to give you a quick update on where we are with the letters that we've been working on. So I'm happy to feedback that the changes to the leaflets that we were making are now complete. So this means this had two strands. The first strand was removing the leaflets that were out of date and no longer needed to be sent to patients. We then also updated the patient information leaflets on Ashford and St Peter's. So patients receive up-to-date information on, say, parking charges and the best places to park, and also the COVID leaflet was updated as well. The new letter templates that were previously approved have been set up on our patient centre, which then allowed us to start the very complicated and long-winded process of configuring them on Cinetech. Cinetech is the company who print our letters and send them to patients. I cannot tell you how difficult this process is, but we are virtually there. So we have 12 new letter templates, of which 10 were signed off yesterday as printing correctly. And the PAS team started the process yesterday of switching them onto the live system, so they will be sent to patients. We have 2 that aren't showing correctly yet, but we're working on it. To link to the letter changes, we also have a text message reminder change that happened just before Christmas. So we now have a generic text message reminder that is sent to all patients. Previously, there were services that were excluded from the reminder, but now it is a blanket reminder that is sent 5 days before an appointment and 1 day before an appointment. And it reminds patients to their date and time of appointment and to undertake a lateral flow test. We've already seen some good outcoming from this. So one of the services that previously didn't send text messages had reported to me yesterday that they've seen a reduction in missed appointments with patients. So I'm taking all the credit for that, but it's just purely due to us now sending out text message reminders. So that's where we are currently. But the next bit of my slide was really to talk to you about the future, because that's way more exciting. So we obviously have Cerner coming live soon, and the Safe Care team are using our new agreed letter formats as a foundation for all the letters. There's a little bit of work to do to align us with Royal Surrey, and also to review the letters that fell outside of the programme of work that I was involved with, such as appointment letters for diagnostics or for day surgery. But I'm sure the Surrey Safe Care team will make the changes required so we have good, robust letters as we go live. The next bit of work that I think is really exciting, and Shirley's joined our working group on this, and hopefully Colin will be able to, Chris will be able to make our next group. We have a outpatient website group to try and improve our current website. So I don't know if people have looked at our current website, but there are some very quick wins we can make to improve the website and make it a really good hub of information that patients can access based around their needs, and not perhaps what clinicians feel. We want to make it very led by patients, what they want to know about their outpatient appointments. The goal we want to get to is that we only send information to patients if they cannot access the website, so we can benefit from environmental and financial benefits on this. And then finally, the bit that I'm going to end on that I think is just going to revolutionise our outpatients is the patient portal, which is called Zesty. So it will go live, we are told, within 12 months of Surrey Safe Care going live. It will allow patients greater control over their appointments, booking appointments that suit them, rearranging appointments easily online. And the benefit in terms of patient letters is it will give patients immediate access to their letters. Currently, it takes roughly 7 days from the point we press print to the patient receiving their appointment letter. So we can save that 7 days immediately. We also, I can see, and hopefully Simon's happy about this, we can make a big saving in costs. So the average letter currently costs 55p, of which 48p of this is the postage charge. So even if we reduce the number of leaflets we send, we're not going to make that saving unless we can look at different ways of getting information to patients. I suppose just to end, that I am aware there are particular groups of our patient population that will not be able to access the patient portal, and we will continue with the traditional methods of communication for them. But I think for the majority of patients, the future is quite exciting. And that's the end of my presentation. Any questions?
So I'm sure there'll be some questions on that. So any questions, Susan? Can I kick you off with one or two, really? One is, if Synatech is so difficult, have we got the right partner? And the second one was the working group. Now, lovely to hear Shirley's on that. Have we actually got patients and carers on that working group? Because they're subtly different. So those are the two questions I had.
Okay, so with Synatech, it's a very good question, and we also had that thought. The guidance direction we were given is, whilst we move to Cerner, it's best not to play with what we've currently got because it would be too complicated to configure another provider. However, I agree with you. I think maybe in the future we need to look at other ways of doing things. In answer to your question about the right members of the group, what we decided in our first meeting was that we would have a small working group and then reach out to different groups to get feedback. So one of the things quite early on we want to do is run some focus groups with different patient groups and carers group, and particularly not going to the average person, but trying to make sure that we create the website so it's accessible to all our patient groups and tailor that in. Okay. So we do have a plan.
Good. No, good. That's great. It's just that we often forget carers sometimes, you know. So Derek.
Good afternoon, Susan. Talking of plans, I'm an outpatient at Ashford Eye Clinic. You see, you're smiling already. When I rang up with having received my last appointment, I needed to change it, and spoke to the lady who was able to do that immediately. And I did say to her, look, don't bother sending me a letter with the new patient appointment time, because it's wasting money in a small way. But if you obviously multiply it up, there's lots like myself. I said, I've got my diary here, so we've agreed it. Can you not send me one? And ironically, a day after I turned up for the reconvened appointment, my new letter turned up, which was a total waste of time and effort, in all honesty. But I noticed you said that there were going to be some areas which were outside of this new patient ability to do it for themselves. I didn't know whether that would include Ashford, perhaps.
No, so I meant I was referring particularly to patient groups that may not be able to access the patient portal just because they don't have internet at their home, or maybe it's too complicated and they prefer to have a letter. But I totally agree with you, Derek. We need to be better at not wasting really the environment by sending letters, and also to save costs in terms of sending letters to people who don't need them, and equally they arrive after the appointment date.
Okay, thanks for that, Derek. Jane?
Thank you, Susan. It's really good to see those improvements. I'm one of the non-executive directors and I chair the quality committee. I don't think we've actually met in person, but one of the things that we had at board was a lady that had some children that had some special needs, and she was really struggling to coordinate her appointments. So I think the ideal of a portal that she can go into, she actually did say she would find that really useful. But she did also offer her services as a kind of almost expert carer user to help with us with our outpatient processes. So I just wonder whether somebody like that might be a really good person. And I know that we have heard contact details. She did offer her help. I just wonder whether somebody like that might be really good to test the system, because she's very well versed with systems. She has to coordinate her 3 children's appointments across different sites, and obviously if they clash, going in electronically would be really helpful to her. I just think that she might be a really good resource to test this.
Definitely, yes. If you could send me her details, then I'll definitely.
I don't have them personally, but I'm sure, Andy, we could arrange for that, couldn't we?
Yeah, I think Andrea has them.
Okay.
Thank you.
Thanks for that. So Michael.
Oh, just a very quick question, Susan, if I may. One of the governors. The after the appointment has taken place, there's often a letter, usually a letter sent to the patient's GP and copied by post to the patient. I wondered, since it's sent electronically to the GP, would it not be a huge saving if it were sent electronically to the patient?
I agree, and the new patient portal, you'll be able to access it online rather than it being sent through the post to you. So we're going to get there. This time next year, we'll all be saying how amazing it is, how we've moved forward.
Thank you.
Great. Okay. Thank you very much, Susan, for doing that. And I think that's very helpful, because I know the governors have been really looking at that area in particular. So we're going to move on now, which will be quite a quick, I think, one. Going back to Chris's question from earlier, the NHSI instruction on COVID vaccination. I think, Louise, if you want to just bring us smack up to date with where we are.
Yeah, not a huge amount to say, to be honest. I mean, so obviously we were working towards a timescale whereby NHS healthcare workers who were working with direct contact with patients would be required to be double vaccinated by the 1st of April. And our target was obviously to try to have ensured that people had their first vaccination by the 3rd of February, because otherwise we would have had to have considered termination of, certainly issuing notice of termination of contract. And during the week that ended the 3rd or 4th of February, we obviously had the decision by the government to review the legislation that had been passed to make it a condition of deployment. And as far as I understand, they're still in a consultation process, but certainly what that triggered for the Trust and every other healthcare organisation was an instruction from NHSI not to proceed with any terminations of contract based on the legislation to make it a condition of deployment. So I suppose, what would I say? I mean, on the one hand, very pleased that meant that we weren't going to be faced with significant number of vacancies as a result of having to implement that legislation. And actually the process of confirming with people their vaccination status has meant that we've got much better records now in terms of how many of our frontline healthcare workers are vaccinated. It goes without saying that it was a significant investment in resource in my team, which feels like now disproportionate given where we are. But I would say that every HR department in the country would reflect the same thing. And as far as I understand, it is likely that the legislation will be revoked, and it's likely that it will also be revoked in the care home system, which obviously was a front runner before we implemented the legislation. So we had a system workforce board today, and we were just talking about the impact on our local authority colleagues who've already transacted dismissals and the process with which they were undertaking to move forward from that. But at the moment, no more news. We're waiting for the outcome of the consultation. We expect the consultation outcome to be that the government is revoking the legislation around making it mandatory.
Thanks, Louise. And obviously, I think that's quite clear. If anybody does have any questions, but I think we are waiting for the next stage to come out from the government, the official position. But I think you're right, Louise. All the indications are about revoking.
Yeah, I mean, and I guess our continued conversation in the organisation is that we believe that the vaccination is the right thing to do. So we continue to signpost people to being able to get the vaccine, and obviously then the booster vaccine. And we also recognise that some of those difficult discussions have had an impact on relationships within teams, where people had taken a particular stance, and that wasn't something that their colleagues agreed with. So we're also just working through all of that at the moment. But as it stands, we are tracking the number of colleagues that are vaccinated, and certainly our data is now in a much better place than it was at the start of this whole process. But yeah, not really any other movement in terms of that, Andy, to report.
Okay. So anybody got anything for Louise? I don't think there's an awful lot further to explore there. Summary is we are still trying to persuade colleagues to take the vaccine and do everything we can to do that. But now we're in the hands of the politicians. Okay, thanks, Louise. So next on the agenda is an update on the hospital building programme. So Tom, over to you.
Thanks, Andy, and thanks, Anu, for sharing the presentation. Apologies to the committee, to the council, that this wasn't shared in advance, but it will go on to admin control after the meeting. And I'm aware of time constraints as well, so I'll try to rattle through these slides. The first couple are really just to remind everybody of the things that we've completed recently, which is quite significant, and supported obviously by the land sale on the west side. So a number of things you can see there: the new accommodation that Optivo are building over on the west side, and clearly that was a joint land sale that we did that supported them, and we've got that new staff accommodation opening up in April, which is really high quality accommodation. We're really pleased to be bringing that online with our partners. We've got the new car park. We've got the new criteria clinical assessment unit and ambulatory emergency area, the 2-floor modular block there that you can see adjacent to the A&E at St Peter's. And then moving on to the next slide, we've got the Wellbeing Centre that was mentioned earlier by David. We've been able to demolish a significant amount of the old ramp and the ramp wards, and we've created the new Willow ward, which is now offering the kind of discharge unit and the palliative specialist palliative care bed. So there's been an awful lot of stuff that's happened. On the next slide, we'll talk a bit more about where we are in terms of what we're doing going forward, and really what's shaping that. So there's a lot of context, I guess, around all of this. We've already talked about the visit from Anne Eden and the challenges around the recovery of the elective backlog. And just to add a couple more figures, from Anne Eden's perspective as the regional director of the southeast region of the NHS, there are in the southeast something like 800,000 people on the waiting list for elective treatment, and 30,000 of those have been waiting over a year now for that treatment. I mean, it is a significant challenge, and from her perspective, the opportunity to invest in a place like Ashford Hospital to provide a facility for the southeast is a really great one. So I'll come on in a bit just to talk about what the plans are looking like for that. But the recovery of the elective position is a significant one. Infection control continues to be a major consideration for us. We're still committed to the North Star objective. We still face significant challenge in relation to social distancing and the need to ensure that the capacity that we have is able to cope with the mixture of red and green pathways. And we heard earlier on how challenged we are just at the moment in relation to the number of COVID patients in our hospitals. So that's a real challenge. The continuing focus on integration and partnership is significant here as well, and that really comes into play in relation to Ashford, which, as David said, we are seeking to do in partnership with the Royal Surrey and the other acute partners within the patch, with East Surrey Hospital and SASH. And then clearly the health, well-being, the greening agenda, the healing arts agenda, and ensuring the safety and sustainability of our buildings. So our priorities on the next slide, coming out of all of that, really are these. And this obviously isn't everything that we're doing, but these are the kind of main things. And then I'll say a little bit more about those. So the Ashford development, which is a major project now that we are in the early process of putting together the business case, which is a significant endeavour in its own right. Continuing with the A&E reconfiguration and refurbishment, the maternity theatre and ward work that we need to do. Continuing with plans that we've started to develop around improving the layout of the theatres at St Peter's, which are not well optimised in relation to infection control. So we need to do some work around that. We've done our recent survey of backlog maintenance shows us there's quite a lot of work to be done on that. We're planning a new store on site at St Peter's, which will help with some of our logistics, but also enable us to complete the full demolition of the ramp, which is currently the sort of residual end of it at the proximal point of the St Peter's site is currently being used as a bed store, and we need to get rid of all of that because that helps us to complete that programme. The catering facilities, which will become part of the Ashford project, and the Eternal Garden, which some colleagues were at the breaking the ground ceremony of last week. I'll just say a little bit in a bit more detail really about what these different developments mean, and apologies I haven't got any more pictures to show you, but these are things that we're working on at the moment. Ashford, as we've said, is a major now system and regional project, and we are looking at placing in there 6 new theatres. We've got 2 already in plan. We want to put an additional 4 into a new build on the Ashford site, along with 2 endoscopy suites that will enable us to offer a full community diagnostic centre service through Ashford, as well as the elective centre that will support the region. Parking at Ashford clearly is a challenge, and the programme will include the provision of a new deck car park at Ashford. Clearly, we'll need to make updates to the mechanical engineering services there, and then the staff wellbeing facilities, which we've already got planned. The new kitchen over at Ashford will complete the picture there. We are looking at completion of that whole area in 2024, and the other element actually which isn't mentioned here is a Macmillan charity funded or supported cancer wellbeing centre that we're looking to install in the courtyard area at Ashford Hospital. So that's another really significant project there that we're looking to take forward next year with Macmillan support. The next slide just summarises where we're at with the A&E reconfiguration. As I said, we've already added in the additional capacity of the clinical assessment unit in the ambulatory care area. We are looking at scoping out the final project. The challenge around that is really the scale and what we can achieve without going into a very, very protracted and drawn out Green Book business case process, which would take a significant amount of time to complete and would not be guaranteed in terms of support. So we're looking to see what we can do in a way which avoids the need for that, but which achieves a new entrance building with improved staff facilities, access to better diagnostic services, and a refurbishment of the existing emergency department that continues the planning that we've been doing now for several years. So the detail of that being worked through this year with a plan to get some building underway towards the end of the year. In relation to the maternity theatre, so we have now, if you just go on to the next slide, Anu. Apologies, I know I am rattling through this, but just conscious of time and to give an opportunity for questions on any of the detail. Our objective really with the Abbey Wing is to provide viable and up-to-date modern obstetric theatres, because we know that we've had major challenges with the theatres that are in that block to date. To make sure that cosmetically there are improvements being done, and we are going to be moving forward with that, even ahead of a kind of major refurbishment of the Joan Booker unit, which will have to be planned in over some significant time, because clearly getting access to that ward for a full refurbishment is going to be quite challenging. We're going to be installing a new patient lift at the rear of the Abbey Wing, because, and this is one of the things that the CQC picked up, the access from the surgical wards, not just the maternity ward and the obstetric area, but also from the other surgical wards into the main theatre suite at St Peter's, requires patients to be moved through other ward areas, and is not best practice in relation to dignity, privacy, and infection control. So the installation of a new lift at the back of the Abbey Wing will solve all of those problems, and then we will also be redeveloping a couple of theatres in the Abbey Wing for the obstetric service there. We can definitely fit one in the existing space. We think we're going to have to do a bit of an extension to fit the second theatre there to provide full resilience on that service. And then we'll be going through over probably a multi-year programme to refurbish the 4 wards, as I've mentioned. And then just finally, just to kind of go into a bit of detail on the backlog maintenance issue, we carry out these condition surveys on a regular basis. We know that we have a significant amount of backlog maintenance liability that we now need to address, and that's been discussed with the Modern Healthcare Committee. We're looking at a 5-year programme to really tackle the high and significant risk areas. And we think the sort of spend level that we're going to need to commit to this is in this sort of area of 6 million a year. We're currently spending about 7 million over the next couple of years in relation to backlog maintenance in the high and significant areas, and then we think we need to continue at the sort of 4 to 5 million over the following few years to give that annual level. And you can see there the split down between the different areas where that is required, but just so that the council is aware that backlog maintenance is a significant part of our estates programme going forward over the next few years. And then just finally, just to finish off with a couple more pictures around some of the new projects that I've mentioned. The Eternal Garden, sorry, it says Time Garden there. That was I think that was the name of it a couple of weeks ago. But the Eternal Garden that we launched the works on last week is a really, I think, important, inspirational project. It's really important in terms of the healing arts agenda, but I think also in terms of inspiring us to do more and more of the kind of greening the environment projects that we need to be doing to be creating a healthy and health-giving outside space. The new staff kitchen at St Peter's, and anyone who's been at St Peter's in the Edu Kitchen recently will know that we're in a bit constrained circumstances there as we build the new, and you can see how that work is going on there in that photograph. We're looking to open that in the next couple of weeks with a big food festival happening, I think, from the 14th of March. And then just the drawing down there at the bottom is an image of the new staff catering servery that we are looking to install at Ashford Hospital, and you probably can't work it out from that picture, but those of you who are familiar with the boardroom at Ashford will recognise that as the servery kitchen behind the boardroom that we will be converting into an open servery linked to the new kitchen, which is being installed below, on the floor below, that will be supporting that whole staff wellbeing area at Ashford, which we'll be starting work on as soon as the Safe Care training has finished. So I'll stop there and take any questions.
So I'm aware there's a huge amount of information there for the governors in a short time. They haven't had the paper ahead of time. So I think, you know, the governors, please do feel free to also submit questions as you look at this through Anu, and obviously Tom will field those, because there's a lot of information there. I guess, Tom, there's one from me, and it's really on the green agenda. Having read today about some of the stuff they're doing at Milton Keynes, which was a lot of kind of solar panels and things like that, and we don't see any kind of ideas around that yet. I was just wondering if the team have started to think about that.
Yeah, thanks, Dan. It's a good question. The answer is yes, in a small way, in relation to things like solar panels. Our decarbonisation strategy, if I can put it like that, is being written into the Trust's green plan, which is just going through approval processes at the moment, and that includes elements of renewable energy, and it also includes elements of changes to the way in which we heat and cool our buildings. And a major thing we need to do at St Peter's, without getting too technical, is to change the heating, the steam-based heating system that we have, which drives hot water around the whole of the St Peter's buildings throughout the year. Which then creates a significant amount of cooling requirement in the summer months. It's inefficient in itself, and then it creates an additional inefficiency. So we need to do a lot of work to reduce that grossly inefficient way of heating the building. And really, any investment in things like solar panels and so on is probably not best made until we've done something like that and started to work on the insulation of the building and so on. So there are things that we need to do ahead of that, but we are looking at some more innovative things around solar powered electric bike charging stations that are just starting to be developed by a local company that we want to trial on site. So we're looking at things like that. So there's lots of ideas. It's really about lining them up in the right way, in the sensible way, and then working with the system around us to get the funding support to do them.
Okay, thanks, Tom. Governor colleagues, any questions on that? Jane, a Ned colleague.
Thank you, Tom. Just really pleased to see maternities with my maternity champion hat on. Really pleased to see that that's in the plan, because I know that was something that we had to park for a while because of the capital cap. Yeah. So I'm delighted to see that's back on the page, and I just wonder if I'm sure that it's early days, I know, but I was talking with the head of midwifery yesterday, and I know that she's got some key concerns about how the actual unit functions. And some practical things like if there is a woman in the birthing centre that needs to be transported to an obstetric theatre, thinking about how we do that, because at the moment that's a challenge. Yes. So it's just sort of those sorts of things where just a little marker to say, make sure that because I know the staff there have got some key key concerns, just to make sure that we engage, and I'm sure we will, but it's just with my maternity hat on, really. Thanks.
Yeah, no, that's well, just respond quickly. No, that's very helpful, and it has been it is a very wicked problem. I think the problem of providing the right theatre environment for obstetrics in a building which is quite constrained, and actually the costs were really quite significant. And of course we had the capital cap imposed on us, didn't we? So that made that very tricky. So Gemma and her divisional colleagues are very close to us and working very closely with us in the planning of it. I've spoken to the midwives as a team recently about what we're planning. So we're working very closely with the clinical team, and the issue of access is a major one here. And the lift, which is a relatively low cost but actually quite important solution. I think we all agree we just need to get on with that, because that just solves so many problems of access from the birth centre, which is the furthest end actually in relation to access to the obstetric theatres, but also from from Labour ward and Joan Booker ward if people do need to get to theatre that way. So it does solve a number of problems. But yeah, we are working very closely with Gemma.
Thank you very much, Tom.
I got the same thing from Gemma today, because I did a walk around today, and certainly that maternity theatre, we desperately need to do something about that, because I'll share it privately later, but some things they're quite worrying, really, the state of that theatre. And I know we've got it on top of our agenda and all the rest of it, but in the meantime, of course, in an emergency, it has to be used.
Yeah.
Edwin.
Oh, hello. I read a lot about electric car schemes, so I don't know, it's a long shot, but it's mainly private companies that can offer this to employees. I don't know whether NHS can offer electric car schemes to staff.
We have a car lease scheme, which you can get electric cars through, and many staff have actually. The number of electric cars vying for access to the chargers is growing, and more chargers will be going in next year. So yeah, we do. I don't know whether there's a way, but we could look into whether there's a way of getting preferential access to electric cars through schemes like that. But we'll certainly we will certainly look at it. And the other thing to mention is that we are going to be embarking on a programme of greening our own transport fleet and turning over to electric vehicles for that where that's possible.
Starting with the electric bike, as we have. Okay, I'm just mindful of time, so we probably do need to move on, but I just reiterate my my offer to governors that once you've had a look at these slides, do submit some questions through Anu, and we will get round to them. So the Urgent Treatment Centre was the next update that colleagues wanted.
Yeah, and thanks again, Anu, for sharing the slides here, and colleagues have seen these slides in advance. I'll run through them. I'll try and run through them quite quickly. So the Urgent Treatment Centre, which the council will know, is provided, service provided by the local GP Federation, NICS. We've been working with them for a few years on providing that service, and it's previously run from the building opposite the main A&E department, it's part of the old kind of war hospital estate. We once we'd opened the priority assessment unit building that I just referred to, the two-storey building, we decided quite quickly that we needed to move the Urgent Treatment Centre facility in there, and we ended up moving it in mid-December, a week and a bit before Christmas. So probably not the ideal time to move a service like that, and we needed to make quite a number of changes to the layout of the building so that we could get the flow of patients right. And I'll maybe describe a bit about why that was necessary. But we wanted to get on with the move because we were facing well, intolerable, really, a situation where patients who were queuing for streaming at the Urgent Treatment Centre, when the queue built up, they were waiting kind of outside, in the cold and the rain, and that actually has been a situation for a while, and we needed to sort that out, and we also needed to sort out the conditions in the streaming area for the staff who are working in that. So there was a sort of twin pressure. So I think we worked pretty effectively with NICS to agree what the changes that we needed to make were, what the patient flow model looked like, and then the estates team rapidly got on and sorted out the changes that needed to be made. And the numbers there, so to translate, 5,820 patients in a month is that's 190 patients a day who attend the Urgent Treatment Centre service and are treated in there, we think they've really benefited, and I'll show some numbers on the next slide from that, as have the staff. We haven't, I mean, it's very early days in relation to seeing sustained improvement. So I'm not going to be able to show you any figures here that show that the performance has rocketed, or, you know, that anything has changed significantly. But what we are seeing are some, I guess, early indications that we hope we can sustain around a reduction in the number of patients that get moved from the urgent treatment centre through to the main ED. Our improvement strategy really is to try to prevent patients having to move from one area of the urgent and emergency care department to another, and specifically to stop them going to the ED if they don't need to, and that they should go into the outpatient ambulatory emergency care type area instead. So the fact that we're starting to see a reduction in that, and we think that is being sustained, is a good early indicator that things are kind of going in the right direction. But we've still got more work to do. So on the next slide, we just talk a bit about the staff well-being, which, as I say, was a really big driver to making this change, along with improving the environment for patients. So we have a lot of good feedback. People like it. People didn't like you know, having to wait in the rain and the cold previously, understandably. But people are giving us good, you know, unsolicited, informal feedback about the environment, and you know, and by and large they like it. And the complaints that we were having before around the environment and around the impact it was having on staff, you know, are not happening anymore. I mean, again, it's early days, but we're not seeing those complaints coming through in the way that they were. And similarly, the staff are saying that it's improving their working lives, their well-being. It's a much better environment for them. Can people still hear me? Because my video's frozen. Oh, no, I think I'm back online. It's always disconcerting when your face freezes in front of you, isn't it? But, so lots of really good early days indicators of improvements in relation to staff well-being, and how patients are reacting to the new environment. And we've been able to provide now a new staff room in the old UTC building, which is a big issue for staff, understandably. And we've had to take the existing or the previous ED staff room out so that we can construct the corridor that runs through from the front of the UTC through to the main hospital corridor. And of course, you know, the long-term plan is to provide a much better modern staff facility in the refurbished ED. So early signs, I think, that things are improving and we're taking things in the right direction. We need to do a lot more work around the clinical pathways. In some ways, we did move a little bit in haste because we wanted to make sure that we had a better environment. So we're continuing the conversations, and they happen on a very regular basis with the GPs, with NICs, around how to make the flow work most effectively. And we are planning a change of process that will start next week, and it will be run as a pilot. We'll monitor it very closely, away from the current system where we have what we call a streaming process, where an emergency nurse practitioner receives the patient at the front end, does an immediate identification of whether or not they need to be seen in the emergency department, and if they do, they get sent and triaged there. But for the patients that stay with that EMP, they then have a quite detailed workup and history and observations, which can maybe take 15-20 minutes. And actually that process, although it's a very thorough and detailed process, can result in the queue forming at that front end. So we're going to be changing that to a quick sort of few minutes for most patients navigation process led by a senior nurse, but ultimately not an EMP, that then rapidly gets the patient to the right part of the system, whether that's the continue into the urgent treatment centre to be seen by an ENP or a GP, whether it's to go to the main part really of the new emergency treatment centre, which is the outpatient-based ambulatory environment where there are physicians and there are surgeons, but people are not in an emergency environment, and they can be properly assessed, and they've got the proper facility for that. Or if they really need urgent care and urgent attention, they will go through to the emergency department. So we're excited that that pilot will be starting in the next week or so, and we'll start that whole process of improvement. And we'll reduce a lot of duplication. There's multiple triages going on at the moment, and we need to clearly move away from that so that we can improve flow through the department. Just going to the next slide, which kind of continues the picture around that. We've got further plans on a longer time frame around following the implementation of navigation, then going to an e-triage model where people who are in the urgent treatment centre, rather than requiring a direct face-to-face clinical triage with an ENP or a GP, if appropriate, they can have there's an e-triage model that they can engage with that will give a rapid triage into the right part of the UTC. We're looking at working on a 15-minute slot basis for patients who have got an appointment at the UTC via the 111 service, and where that can be provided. We're clearly looking to continue with the development of the workforce model and the business case to provide the full investment in staff for that particular area. And we're looking to see how Cerner and Surrey Safe Care can be deployed within the UTC, which is currently running on a different primary care service, because that will enable it to be the referral of patients from the UTC into the hospital, for that to be done seamlessly on a single system, and we're just exploring that at the moment. So in summary, I think the fact that we are now in a single building in a new environment is a big tick in the box. We're all very pleased with that, and we're getting good feedback from people, but there's still and showing some early signs, I think, of improvement around some elements of performance, but still an awful lot of work to do. But we're actively piloting new ways of working from next week. So I'll stop there and take any questions.
Thank you, Tom, and thanks, Anu, for sharing. So we're going to take Andy first.
Yeah, Tom, I think I had already told you about the old signage that had to be moved, and you've done all that outside the building. The thing now is, if you follow that signage, you don't have any sign above the door that you go into. It just says Rowley Bristow. Mm-hmm. There's nothing there saying Urgent Treatment Centre or the AECU unit, which just seems a bit of a miss, because if you look at your previous sign, it says carry on walking, and they could well walk past that door and not realise that is the entrance.
Yeah, thank you, Andy. Thank you for raising that point initially. Yeah, we need to, I'll pick that up, because we need to complete the job, don't we?
Yeah, because once they get inside the door, then there's the signs, but you've got to realise you've got to walk through that door.
You've got to go through. It's quite an important part of the process, isn't it? Yeah, I'll pick that up.
Yeah, thanks, Andy. Good spot. Michael.
May I ask Andy, if a patient goes to the urgent treatment centre and it's not deemed necessary to send them into the emergency department, but they do require medication, is there any facility for them to receive that without having the rather tortuous route from the new centre to the hospital pharmacy?
Good question, Tom.
I think it probably depends. It probably depends on what kind of medication that they need. If the GP can prescribe that medication, it can be picked up at the local pharmacy. It can be done. It can be done that way.
So they can issue a prescription.
Yeah, they can do that. I mean, what we probably need to think about is whether if somebody needs to have a more in-depth workup and assessment by one of the physicians, whether or not that can then lead to the issuing of what we call an FP10, which is an outpatient prescription.
Yes.
And that would actually smooth things up as well, because again, that could be picked up from the local pharmacy and avoid a trip to the hospital pharmacy. But frankly, once you're in the ambulatory emergency care unit, it's not that far around. So yes, I think the simple answer is yes, and we just need to work out what the appropriate approach is for different types of patients.
Thank you,
Andy.
Sorry, I was just going to add, if you are in the ambulatory AECU unit, it is a short walk, provided you haven't closed that corridor off for the emergency department. So,
right.
you know, what we were advising people at the UTC was it was the long walk round, you know. Mm-hmm. So, yeah, there isn't a quick route.
No, because that corridor is often shut, as we know.
That's right, yeah.
Colin.
So, is there a cost consideration by asking a GP to prescribe? I've come across this before, where at the clinic I've worked, and we would always ask the GP to prescribe because of cost considerations.
There is there is only in the sense that a prescription, an FP10, you know, is charged to the primary care part of the system, whereas a hospital dispensed medication we pay for. But we're all one happy system now anyway, so that can be dealt with and shouldn't be an impediment to getting the right and most convenient approach for the patient. So I mean, I think the issue is who should be doing the prescribing and what's the most convenient way to get the medication to the individual.
Yeah, it's often sometimes difficult to access the GP. I think delays.
That's right, but I mean, I think, you know, people who need repeat prescriptions and all the rest of it often can do that now online and so on in primary care, and shouldn't need to come to the urgent treatment centre at all. So I think, you know, there are you know, more and more ways coming on to make access to these things more and more convenient.
Yeah. Okay. Anything else? I'm just conscious of time, but we will gain on the next bit, I promise. Okay, so Tom, thank you for that. Thank you for both those. Hopefully, governors, you've now seen, and I think actually Tom kind of almost undersold the amount of work we've done already, because, you know, we've also refurbished the nursery in St Peter's, built a new nursery in Ashford, put a new theatre in Ashford, refurbished two theatres in Ashford. So actually, understated really, Tom, what the building programme has done. So we've done a tremendous amount with those funds that we realised from the West site and from Ashford, and a lot more to come, contingent obviously on getting the money for the elective centre, which is underway. So thank you for that. I'm going to ask if I've not been notified of any other business, but has anybody got any other business for the open Council of Governors?
We have Rosemary with us. I don't know if she wants to raise anything.
Jen. Right or not? Miss Rosemary. Somebody just said, "I'm here."
Yeah. Rosemary, it was just a whether you had a particular question or not for this.
Well, I didn't know we were. I know you used to do questions from governors, but at the moment you're just doing it on the
We're doing it if you've raised
on the board,
one.
aren't you?
Yeah. But if you had
yes.
a burning question.
Okay. Well, actually, as one of the things that was spoken about today is about your building work at St Peter's, and I raised at the last board that about Headley Court not going ahead for Ashford, for Surrey and Borders. So what I'm is now the case is that Farnham Road Hospital in Guildford now is the only NHS hospital left in Surrey, and that means that mental patients will be going to any patient that doesn't go into the new Spencer ward, which hasn't been quite started at on your site, will go into private provision, which will be paid for by NHS money. And just earlier on today, I was at a focus meeting, which, as you know, is Surrey and Borders for users and carers, and we have had a presentation from Alex Wilson from the the group that's organising all the new things and talking about OxyHealth. Now, what's happened is that OxyHealth, very, very good system of monitoring patients' remotely, and also viewing them on camera. And of course, the staff was put into wards in, I think, a couple of wards in the ACU. But of course, the ACU is supposedly closing at the end of this month, or part of this month. And so I was asking Alex Wilson about what about when people who won't be able to get into Farnham Road Hospital, because it's the only hospital in the whole county. The people are coming from east, west, south and north and everywhere, and they go into private care. Are these provisions, these hospitals, which will be the Priory, Signet...
Rosemary, I can't answer for Surrey and Borders.
No, but I'm just, no, you're not going to be able to answer it. I'm just pointing out that...
No, we do know that, but it's not really a matter for this Council of Governors, because we have no control over Surrey and Borders decisions.
Neither do they. They're waiting for the government to tell them whether they can have the money to build the hospitals. I'm not asking you to answer the question. I'm trying to give you the information.
No, we know the information, but what Annie was saying was whether you had a question for the council, obviously on something.
Well, the specific question then, which I've been very concerned about for all the years that I've been coming to Ashford and St Peters, and of course yourself with your knowledge of Surrey and Borders, because you were a NED there, is the interface between the general hospital, the 5 general hospitals in Surrey, and the one mental hospital in Surrey and Borders. And the problem is, what I see is that mental patients, and I'm talking not just about my own relatives, but as I see a lot of others, that the general hospitals are actually doing most of what Surrey and Borders should do, because you look after a lot of dementia patients, you look after a lot of people with autism, with all kinds of conditions. And Surrey and Borders, well, I really think the reason that, can I just say that the reason that the Abraham Cowley unit was opened on your site, a very short way from the A&E, was because back in the 80s, the idea was that people would be in the community and that mental hospitals really would only be short stay places. And that hasn't happened. People are now stuck, as my brother is, for years on end.
Yes.
Anyway, I'm just bringing this to your attention. You've invited me to ask a question. The question is, are you really understanding the seriousness of the situation? That the general
from a system point of view, yes, we are. We are very close to Surrey and Borders. We understand their issues and they understand our issues, and we are working with them at system level, and that's both at place level and across the system. So that's, I can give you that assurance.
I know that's the intention.
But what I can't do, Rosemary, is go on any longer, because we're over
you
now.
invited me and you've opened the floodgates.
Yeah.
And here I am. I'm quite silent when I'm supposed to be silent. You know that.
No, I understand.
sit through all these things, and can I just say I'm very, very grateful to Ashford and St Peters for the way that you do these, stream these live, and you also put them online, because it's very difficult. It's been very hard to get Surrey and Borders to even put anything, and now they do audio, and they hold in-person things in Dorking halls.
Yes.
I mean, really.
I understand your frustration, Rosemary, and of course, how close you are to it through your brother. So we do understand that.
And other patients. I mean, the thing is, I am just the tip of the iceberg. I know I'm always there, but the fact is there's only me, and I find it very, very difficult to get anybody to understand how important it is to come to these meetings.
Yes.
And anyway, the online thing is great, because you do put it very efficiently online, and sometimes I don't have time to sit through these very long meetings. Well, you have to. I don't know how you do it. Anyway, thank you for...
Okay, thank you, Rosemary.
Okay.
I'm going to close this meeting now. Anu, have we got a separate link for the next meeting, or are we carrying on this one?
It is the same link. I just need to put the recording off now.
Okay, thank you. And I think have we lost the